Welcome back to Data Nerds. I am Mike Brown, joined by
Pat Healy.
and Pat has a case for us. So Pat, take it away.
Damn straight I do. So, what we got here today, if you're an audio listener, go freaking check out the visuals on YouTube. All right. Come on. What are you even doing at this point? But what we got is some isometric testing that I did back on June 13th of this year. That would make sense since I didn't start my job since August of last year. So I don't know why I said that, but
Listeners
what
don't
we
know
have,
that. So
I know, yeah, that's a good point. So what we have is some isometric testing for knee extension and knee flexion. I know we've covered this topic in the past with a few clients of my own. This test was completed on the HUMAC norm by CSMI. And this was completed at 60 degrees of knee flexion for 3 trials, each being 5 seconds each, with a 10-second break in between. The participant had 5 warm-ups that each were 10 seconds of rest in between, with a 30-second rest between the warm-ups and the actual trials. They did all knee extension first and then knee flexion, and then we went to the uninvolved limb. So we did involved first, then uninvolved. Reason I like doing that is just from like a warm-up period. I usually have the person warm up before we do the testing, and then I've had just some people in the past tell me that by the time that we do their involved limb, they're like, yeah, my limb is like cold now. So I usually like to do the involved first and then uninvolved. So little background on what we're seeing here. This person is pretty much exactly 6 months post-op ACL reconstruction, but not just ACL reconstruction. This person is a ACL reconstruction with quad tendon autograft, medial meniscus repair, lateral meniscus repair, chondroplasty of the lateral femoral condyle with a biopsy done, and then a assisted MPFL reconstruction with a semitendinosus allograft. So, pretty complex surgery. You know, you had a lot of structures that were repaired or reconstructed in there. So because of that, this person was non-weight bearing for 8 weeks. So I bring that up because I think this does play into what we're seeing here, be it that they are 6 months post-op now. For anyone who is unfamiliar, in the probably earlier times of ACL rehab, 6 months was relatively a time point when people would start to return to some higher levels of activity, you know, some running, higher levels of running with the anticipated participation in sport at like 9 months. If you are up to date on the literature, you would know that for majority of people outside of like maybe some professionals, it's too quick of a timeline, especially for those who have more complex surgical procedures done, much like my patient here. Reason being is that we know even after just a week of non-weight bearing, we see some atrophy in the quads. So you take that and times it by 8, that quad gets very inhibited, becomes very atrophied, and just becomes a large hole to dig ourselves out of. Now, pre-recording, Mike asked me, so is this your first test? Do we have anything to look at? Because it is 6 months. And to that, I told him to hold his horses because this is the first test. And, you know, I think a lot of critics out there of strength testing might say, well, that's pretty late to get a strength test done. And I would agree. Now, why I did it at this time and not earlier is because up until this point, this patient has had painful reproduction of symptoms with mechanical loading, and I did not find it valuable to do a test when it's still very painful to even just do knee extension. So we just waited a good like 4 to 6 weeks. I don't have like an exact timeline, but over those few weeks before the tests, um, no mic, nothing I'm playing is picking up audio, I don't think. I don't
Just
think so.
that
Maybe there's something
I
outside.
I had put something in a private chat to Pat that it was like some audio is getting picked up if if
Was it
you're playing with
is it
something.
is it me fiddling with my paper? That might be it. My bad.
It might be it.
Okay. All right, I'll stop doing that. All right. So what happened was this patient was having very low load tolerance, and it comes down to that kind of idea to where, all right, this person can't even do knee extensions really with any kind of significant resistance. What am I really going to take away from doing a strength test, you know? So I gave her a good few weeks of just training, letting symptoms come down, waiting for a positive response for a few weeks to knee extension and loading. And with that, though, I was having her do this exact protocol on the HUMAC norm as a training stimulus. So that also gave me good insight into when is she going to be probably appropriate to actually do a test, because every time she came in, I was getting her on there and putting her through isometrics at this position and monitoring like, hey, how does this feel when you do it? And up until this point, it really is just a lot of pressure feeling for her, which I'm fine with a lot of pressure, but it's not painful anymore. Um, so, that time went by, finally did the test. And for our audio listeners, we are seeing on her uninvolved side, which is her left, a peak of 141 foot-pounds, which is around 84% body weight. And then on her involved side, which is the right, we're seeing a 78 foot-pounds and 46% body weight. That puts her at a 45% deficit. And for anyone who's unfamiliar with the literature, we are kind of looking at a 100% body weight criteria. And that's out of, this is what you need to hit to be able to start doing some higher level activities. Not like an absolute switch, of course, but like you should be pretty damn near that. Um,
I have
and
a
then
question. What maybe you already said this. What sport is she trying to get back to?
volleyball potentially.
Mm,
She was a college student athlete, but now she is done with college, and so
gotcha.
it's kind of like she would like to play volleyball, but she doesn't have really a team that she's going back to. So
Gotcha.
I'm still going forth with the idea of like, you're 23 years old. Like, I want you to be able to jump. I want you to be able to run. Like, you're too young not to do these things.
Yeah, for sure.
Um, so then if we look down at knee flexion, uninvolved side, 71 foot-pounds with 42% body weight. Right side, 59 foot-pounds, 35% body weight, deficit of 17%. We're looking for about 60% body weight on that one. So both of them not too hot really, but obviously our bread and butter here is going to be that knee extension, especially with that quad tendon graft. So with that in mind, though, we would expect that these values might take longer to come back. Now, I will say this individual was not the best at doing their home exercise program. Um, they would they would come back and admit to not doing it at all. Now, part of that, of course, she was going through a lot of life changes. She was switching jobs, moving apartments, but in that same breath, you're not going to really see much improvement here if the work isn't being put in outside. So, she was able to put in a solid like 6 weeks of work, which I think got her to where she is now. Um, but definitely, in my opinion, probably could have been further ahead than where we are if there's a little bit more diligence on her end. But, we're going to take what we
How
got.
far ahead do you think she could have been? Like, if you had to
I think
guess, right?
I would have hoped that she would have been at least like 80% body weight. Like I think that right side could have been at least at like 130 to 140, truthfully, because if we're being honest, I think the first few times I had her do knee extensions isometrically, which was like pretty much all her effort she could give, she was resting at like 30 to 40 foot-pounds. And then
Wow.
only in the past like yeah, and then only in the past like 4 weeks has she been able to like breach up to like 80-ish. But that's actually a good point to bring up. So she did this test, and then a week later, I had her come in, and she said she was feeling very good. And just during our training, I'm like, okay, these last three, I want you to like go as hard as you can. And she hit 86, and that was a week after doing this. So she
80,
almost
86 peak torque.
yeah, so she almost like
Yeah.
improved her peak within like a week, which I think goes to show like that neuromuscular rehab. I don't think a week is going to get you true strength gains outside of just like that muscle not being inhibited as much. Um, but
Yeah. I have
so
lots of questions too.
what's
I
up?
don't know when you're opening up for the peanut gallery, but I've got
Yeah, well,
um
I just
yeah.
want to point out. I think the last
Mhm.
thing is the importance on rate of force because if we look at her curves here, the left side you get a pretty steep cut up until the peak within the first second. While she doesn't really hit her peak on the involved side until like 3 seconds in. So I think this brings up a good conversation of, hey, like right now you're just trying to like hit this absolute value, but then there's going to be bigger tasks for us to try to accomplish here because if we're talking about sport is all about how much force can you produce in the shortest window possible. And right now she needs a big window to try to produce 50% of her body weight. So
Yeah, that's I was gonna ask like for RTD things like rate of torque development, are you looking at the like torque 20 to 80% slope there?
um no. Uh to be honest, I have not had a patient at currently who I'm too uh what's the word I'm looking for? I'm not too worried about rate. So this patient theoretically is going to be the first one when we finally get to that point that I will truthfully care about that. Um I currently do not have a best procedure for it just because I do think rate of torque development is such a hard thing to actually get a good value on. Um, I would probably have to ask one of my coworkers who's played around with it a little bit more about like what technique he's found to be the best and through the colleagues he's connected with. Um, just because like the 20 to 80% slope one, you're missing out on that first bit, which is also important. Like why
Yeah.
isn't like 0 to 20%? Like that's important. Like that dictates, force that is still force being produced that is necessary for like sport and such. So why are we saying that's not important? And we're just saying it's not important because it's messy. It's like we can easily get that 20 to 80%, but like, yeah, that will tell us something for sure. But is it really getting at the most important aspect of RTD? So,
Yeah,
um,
that's fair. I feel like that would also be easier on an isokinetic test as well. But I don't know, maybe not.
yeah,
Um,
and I think that's a fun thing to bring up also. So, I only did isometric with her, where I think sometimes a lot of my coworkers might do isometric and then straight into isokinetic. But and this is just an opinion of my own. If someone isn't producing torque values within what looks qualitatively as a good rate, you already know that isokinetically it's going to be garbage because, like, if they can't even produce that torque in one position in enough time, why do you think it's going to be any good when you start moving the limb, you know?
Yeah, yeah. So it's like it's not worth wasting your time doing that because you already know it's not going to be a good measurement, is what you're
Yeah,
saying
like
there.
yeah, and like I could be convinced otherwise, but that's just my opinion. Like if I do isokinetic, the only thing that it might give me that I'm not getting from this is where is she having the greatest deficit at currently? Um, but in that same vein, that obviously isn't the lowest hanging fruit. Lowest hanging fruit right now is just getting this entire thing up, you know? So
Yeah. Yeah, I have another question too, just to confirm. So she had quad tendon graft, so that's probably why she was having like some pain with the knee extension. But then did
yep,
you say too she also had a semitendinosus graft for
that was an
a different
allograft.
an allograft? Oh, okay. So
Yeah, but that was for a MPFL reconstruction.
okay, because I was gonna say like if she had, I was gonna ask about like her hamstrings too. Like, would you expect more deficits? But yeah,
So if she did have an autograft, for sure, like that's just a hamstring strain, right? Like you
yep,
take a graft,
yeah,
you so, um, but so yeah, with that quad tendon graft, it's just going to be a lot harder to get that knee extension peak torque up, and then especially like the rate of it all, right? So, um, but you know, nothing we can't try to come over with some hard work, but we'll see where it goes. Like I said, she already improved by almost 10 foot-pounds within just a freaking week. So we'll keep on tracking and go from there. But um, yeah, that's kind of everything that I got. You know, I think right now, what am I doing to go forward? Just kind of the same thing we've been doing, you know, like emphasizing both compound movements within like, I don't want to say comfort, but like I don't like when people do sloppy compound movements after a surgery. It's just like, what are you doing? You know, it's like if you're doing a shitty step down, I'd rather have you do a better step up or like a better kickstand squat than just like force the peg into like force the square peg in the round hole. You know what I mean? So like,
yeah. Yeah,
um,
I'm the same way with like compounds and stuff. Like I just like I'd rather like isolate stuff until they get like they look how they want to look. That was actually a question I had too, is like so we can see these numbers, like we can see there's a 45% deficit in peak torque and like especially the different things that are talking about rate of torque, like with the torque at 200 milliseconds, torque at 400 milliseconds, like 80 and 76% deficit, like that's a lot. um are like what functionally does she look like does she have any sort of limp at this point, like how does her squat look, that sort of thing?
yeah. So does she have any kind of limp? Like if she comes into the clinic after a full day of work, this person works as a chef. She's on her
Mhm.
feet like 10 plus hours a day. Sometimes she'll come in and like for sure, like, she'll come in and she might have like a little bit of a limp, but like on days that she's like rested, she looks perfectly normal. Um, her squat, like she looks great up until around 45 degrees of knee flexion. And then after that, like she starts to stress shield and move away from it. Um, and then like trying to expose her to like a single leg squat or like a kickstand squat, like man, that is like the hardest thing for her, you know, just like that very slow eccentric. Um, Usually I'll try to like put something behind her back. So then it's like, okay, I don't want you to just like poke your butt back. Like I want you to stay a little bit more upright to try to emphasize more of that positive shin angle in the knee excursion to get more quad dominance. But you know, she'll send a few cuss words my way if I do that. So um but yeah, that's like functionally kind of what she looks like. To like address that quad tendon graft, I we'll have her do like Bulgarian split squats, but emphasize rear foot. So trying to get that rec fem really on a lot of stretch there. Um,
Mm.
so that's something that I try to keep programmed in for her. She has equal range of motion both in like a supine position and on a prone position. Because sometimes with people who get like a quad tendon graft, that prone position, just when you get that extra stretch on the rec fem, can highlight a few deficits. But she's doing great there, which is awesome.
Is
Um,
that equal front like intra limb? So like her right limb is the same from supine and prone, or are you saying it's symmetric interlimb, like right and left, or
Symmetric
both?
interlimb. Yeah, yeah. So both, yeah, totally. But like interlimb, it used to be it was for the first like 4 months, we were just doing it supine and just trying to get that back. And then once she had equal range supine, then I put her prone and that highlighted that, oh, okay, like interlimb, she is still having some deficit here that we need to address through just like a classic like on your stomach knee bend. Um
Gotcha.
yeah. And so my next step with her would be to try to hit up some reverse Nordics, but she's quite a few months away from that, I think.
Does she still have any like reactive swelling or anything like that?
Honestly, not really. Like I pushed the hell out of her in clinic and like she'll come in with a 1+ and she'll leave with a 1+. That was another thing. That's a great point to bring up. Her swelling was very hard to control for a very long time, and her symptoms, like kind of like what I said earlier, I didn't really test her just because of symptoms, but like, yeah, her symptoms were not well controlled for a long time. Um, and I think that kind of brings another opinion of mine to where I think you know, there needs to be a little bit more of a chill kind of approach with some of these more complex patients. At least that's just like something reflecting back on it for myself to where, okay, these symptoms should get better if you kind of just let this limb kind of just chill and not just, like I said before, force a square peg in a circle hole if it's not the right time, right? Like, I can't rush physiology, so
Yeah.
why try to rush it? Like I'll do everything I can to give a good environment to help her function better. But if the limb isn't ready for mechanical loading, the limb isn't ready for mechanical loading. It's just like it sucks. But I think gotta have to recognize that sometimes and just reinforce the patient that like we will get there, we will be able to get you stronger. It's just right now that limb is still recovering from the operation and we have to respect it.
Yeah. Yeah, that's fair, and that's why I asked too, because I still have some people like more like Achilles issues, where they're still having reactive swelling like 6 months later, and it's like that's tough because you want to be doing more, but it's like we really shouldn't be doing that much more right now because your leg's just not handling it.
Yeah, I think educating any kind of patient who has an operation on reactive swelling is one of the pieces for lifelong learning to keep them functional, and try to keep them from like spiraling with sustained symptoms again, like having chronic symptoms. Just because, I know many people who have had ACL surgeries when they were in their teenage years and now they're 20, 30 years old, and they will still get some reactive swelling here or there. And teaching your patients how to do like a sweep test, especially if it's for the knee, I think could be very powerful to give that autonomy to the patient of handling their own symptoms, educating them like, hey, if you're doing this and it is coming right back without you even sweeping it back, you should rest, like you shouldn't try to push through this. Because that's going to be with them forever, sadly. Like you can do all the strengthening you want, and you can do all the rehab you want, but sometimes whether it just be extra stress, less sleep, could just flare up that reactive swelling again. And I think just giving them the tools to be able to monitor it themselves so they don't just keep on forcing through it is the best thing you can do also.
Yeah, giving some like exercises, like easy things to do to help get that down too. Even if it's
Yeah.
like, hey, you notice some reactive swelling, like maybe you have a brace that you wear the brace or something like that.
Yeah. Or like, you know, for someone who is like very active, stating how, hey, maybe you can't go on a run today because you're just very swollen, but, going on the bike on like low resistance actually might not be the worst thing for you. It might work as a good like pumping motion, just gets the limb warm and all that. It might not be what you want, but, when in life you kind of just have to take what you can and not cry about what you don't.
Yeah. So I'm also curious, like you've talked about some of the things you're doing, but like what does a session look like for her? Like what sorts of like what is the programming?
That's a great question, and I'll send you my Excel sheet for her programming right now. Just kidding. Yeah, no. So how it normally happens, because she has such a major deficit, we are still doing STEM. I think based on the literature, they say that you should stop doing STEM when someone is within a 20% deficit. Um, but honestly, if someone is still like below 60 to 8, like this is going to be a large window. I understand that. But if someone is below 60 to 80% body weight, I still think you should be doing STEM. Like, why would we say it's an LSI thing? That doesn't make sense to me. But um, so usually how it happens, she comes in, she warms up on the bike for however long she wants to. Some days it's 1 minute and then she just says, I'm done. Or some days it's like 5 minutes because she just wants to yap, whatever. Um, and then after that, we'll go on the table, check her swelling, check range of motion. Usually range of motion, I'm just making sure she can like still get her heel to her butt in a prone position and her extension is still the same. From there, pop on the stem. We'll do just like sitting right there, just a few quad sets with the stem, literally just do like 5 or 6, come off the table. Then we'll do some stem TKEs with our like cook straps, like those big resistant bands that have like the padding behind them. We'll do some of those. And then we'll get into a few of our compound lifts. So, like our one compound superset I have programmed is her Bulgarians, and then going into some heavy heel raises, like a front foot elevated heel raise with a wedge. Um, it will go back and forth on that, keeping like her sets and reps below like 8. So we'll do like 4 rounds at 8 reps each. And then her second compound will go into a kickstand RDL with her back foot on the wall to really try to emphasize, like, all right, you're stable. And now you can emphasize a lot more length on that involved limb. And then with that also, we'll do the kickstand box squats. And then from there, time dependent, we might have like another compound in there. I can't remember off the top of my head kind of what I have in that block without looking back on it, but that's usually majority of like our compounds that we're doing. And then I will have her go to the humac, and then we'll finish off with doing some isometrics. And then if time be it, I will put her isotonically and then be like, all right, literally just go for as many reps as you got at this resistance. Um, this actually brings up a good point. So, as we see in her test, her rate of force is so poor. So, the first few times I was having her do like an AMRAP just to try to get that physiological boost for like hypertrophy and such, it would take her forever because I would either put the resistance high, so when it's a challenge, but it would take her 3 seconds to do a rep. So she's sitting there for like 6 minutes, still going because she just has no ability to produce force quick. Oh, but then I take it down, and then she's still there for 6 to 8 minutes because it's so light. So this is a case in point to where I use BFR, because then
Yo, I was gonna ask about that.
yeah. So this is a situation where I do use BFR because of her rate of torque development being so poor. I will put that on, keep the resistance low. That way she can go through the motion quicker and really get that metabolic stimulus going. Um, and that has worked in the past. She doesn't like me when I do that, but oh well. So yeah, like depending on the session, depending on how much time we might do that. But so far, usually we just cap off the session with doing some very, very hard isometrics or very slow isokinetics.
Yeah, nice. So like a tough finisher for her.
Yeah,
How
yeah.
many times a week is she coming in?
Ain't that the kicker also, right? So she was coming in twice a week, um, but she just moved to a town that now her commute would be over 45 minutes to the clinic. So that's going to be a problem. But that's kind of where that conversation of her not being very diligent with her HEP kind of comes into play, where I I had an honest conversation with her because she'll ask me like, "Oh, when are we running? When are we doing this? When are we doing this?" I'm like, when you show me that you're ready to do it, and right now you're not, and like until you start doing the work to get yourself there, you're gonna be at this same point, and we're just gonna keep on doing this over and over and over again until you understand that this is where you're at, you know. Um,
Yeah.
so I have like tried everything. She has been going to the gym as she's told me lately. I haven't seen her in like 2 weeks, so I don't know if she's still doing it. But with that new commute time, kind of stressing the point like going to the gym is going to be extra important because I understand you don't want to be driving here and spending 3 hours of your day driving to PT, doing PT, and driving home.
Yeah. It then makes me think like, you know, again, her as harkening back to like our initial like our initial things that we talked about was like how, potentially her recovery timelines could be quicker. Um Part of that too is like then maybe she tells, someone else about what she's doing, and like a PT could be like, "Oh wow, like you're doing a lot of like good stuff at PT," but then like, the frequency just may not be what she needs. But then maybe she's telling other patients, like other non-PTs about what's going on and being like, "Yeah, my progress is just so slow." And so like I guess where I'm going with this is like the two different perceptions of the same thing, just based on like, from a rehab standpoint. Like if I was working with someone, um, I'll say like, say she stops going to you, starts coming to me, assuming, I'm in
Yeah.
Washington and not on the East Coast. Like 8 months out, like because she stopped going to you because I'm now in the town that she's in, and she was telling me like what she was doing, I'd be like, oh, that's awesome. Like you're in a really, like you had some really good PT. I've had the opposite experiences with with some people that I've been seeing post ACLR. Um, I feel like unfortunately other patients would be like, "Oh, like you're 6 months out, you should be running. How are you, like, why aren't you doing that?" And then it's like, "Well, my PT's not letting me." So like there's these, could be these two like polar
Right. I see.
opposite
Yeah.
reactions to the same thing.
Yeah. And like she knows it, like she knows it. Like she knows she hasn't been going to the gym as much as she should have been, and she knows that like this leg is still doing crappy with, whether it be like kickstand squats and everything else, like those functional movements. And so I think I see what you're saying. Um, but with this patient, she does have that kind of a personal insight to be like, oh, this kind of was on me, you know?
Good, good. Like
Yeah.
that, because you don't want it to look bad on you where it's like, well,
Yeah.
she's not where she needs to be. It's like my PT's fault. Like, no, I'm doing
Yeah.
all that I can.
Yeah.
But
Yeah, exactly. So, but that's yeah, that's this case. And I think it's, for as much as I talk about, whether she has or hasn't been doing, this has been like probably my most extensive surgical case so far, and like my most prolonged case I've been working with so far. So I don't know. Well, I'll be interested to see kind of how long we can ride this train and keep on going, because of course the issue becomes health insurance.
yeah,
Right?
yeah, I was gonna,
It's like
I was,
we
I was
are
like, oh,
we are deep into coverage, and it's just biding time, until we might get like that peer to peer of, so how many more visits do you think she needs? Um
it's like a million. Who
Yeah,
knows?
right. So, we'll keep on doing what we're doing, but I don't really think much is going to change in terms of programming until what we're looking on this piece of paper right here significantly improves. So,
Fair. Well, I'm curious to see what the paper looks like, in 2 months or something. So
yeah, it
keep
should
us
be good.
posted on this.
Should be good. Hopefully.
Yeah. Well, cool. That's been a little longer one, but yeah. So here's the end of the session. As always, if you enjoy what you listen to, please leave a nice review on Spotify or Apple Podcasts, or if you're watching this on YouTube, like you should be doing, so you can look at the stuff. Uh, what is it? Subscribe, like all the things. We appreciate it.
Smash all buttons. Smash all
Yeah,
buttons.
ring that bell.
Ring that.
uh, but yeah, thanks.